I am Dr. Lucy Maria De La Cruz, and I'm the Chief of Breast Surgery as well as the Director of the Betty Lou Ourisman Breast Center at MedStar Georgetown University Hospital. The type of patients that I normally see are patients who have been diagnosed with breast cancer or patients who are considered high risk or have benign breast disease. Patients who are high risk are usually those who have a strong family history or have a deleterious mutation who have been tested for such. I also have an interest in male patients who have breast cancer as well as other benign disorders such as gynecomastia or breast pain. My philosophy when it comes to patient care, it's very much in tune with the philosophy of MedStar Georgetown University Hospital, which is cura personalis, and it has to do with taking care of the whole person. One of the things that I really truly value about our field is that we're able to treat the person in a multidisciplinary approach and make sure that their journey is a unique journey, an individual journey, and not, one size fits all. And when I became a resident, I met a patient on my first year who had breast cancer, and she really touched my life. She made me realize that I can be a surgeon, treat women, and also create bonds that were lifelong bonds with patients and be a crucial part of their journey. And so I find that this is a very special field, and I couldn't see myself doing anything else. A lot of things excite me about the future of breast cancer surgery. There are so many advances that we're doing thanks to research, not only in the medical field as far as like medical oncology, immunotherapy drugs, vaccines potentially in the future, but also as far as the radiation oncology field. There's a lot of new technology that's coming out that we have here as well available at MedStar Georgetown University Hospital, and as well as surgical management of the breast cancer. When I graduated from medical school, the way that we treated breast cancer is very different than what we are treating today. And so as I see the evolution of the treatment of breast cancer, I get very excited because ultimately I hope that one day we won't be treating breast cancer, but we will be preventing breast cancer with treatment. Patients should come to MedStar Georgetown University Hospital first and foremost because it's an NCI designated comprehensive cancer center. And what that means is that we are held to higher standards across the board compared to other cancer centers. It is the only one in the region, and we have a multidisciplinary comprehensive center for breast cancer treatment, which entails breast radiologists, medical oncologists, radiation oncologists, plastic surgeons, all who specialize specifically in breast cancer treatment. We have state-of-the-art and cutting-edge technology in and outside of the operating room, as well as we have great supporting staff such as our nurse navigator, our social worker, who will help the patient navigate the system, as well as providing them access to other services such as support groups, other services such as transportation that they may need along the way. Aside from that, our staff here provides personalized care for patients day in and day out. I was intended to do this. So when you do what you love, it's not work. I always tell my patients that I get a lot more from them than they could do from me. When they tell me thank you, it's truly a blessing what I do. The difference between lumpectomy and mastectomy is the amount of tissue that we remove. When patients have a lumpectomy, it's essentially removal of the area of the cancer with a rim of tissue around it, which we call a margin. A mastectomy is the removal of 98% of your breast tissue, but we're not removing skin or chest wall. We're just removing breast tissue. The reason why someone would have a lumpectomy versus a mastectomy is really done based on patient to patient. We look at a lot of things in order to make a surgical decision. The first thing is tumor size and the breast size. So depending on the patient's breast size, whether they have a small breast or a larger breast, then there are more options. So if someone has a big tumor in a small breast, obviously those patients we normally or would try to recommend a mastectomy. If a patient has a big tumor in a big breast, those patients sometimes we can do a lumpectomy or a mastectomy. And obviously there's different scenarios that we go by, but that's a decision that patients usually do with the surgeon, and it's very personalized to them. So the difference between a lumpectomy and a lumpectomy with oncoplastics is essentially lumpectomy alone, I remove the area of the cancer by myself and I take a rim of tissue around it. There are some patients who are large-breasted who are benefiting from having oncoplastic surgery. An oncoplastic surgery is essentially me removing the cancer part, which is the onco part, and then a plastic surgeon doing the reduction and the lift. So patients after surgery, they wake up and they have their cancer removed, but they also have a reduction and a lift in both breasts. So the person who gets lumpectomy versus a lumpectomy with oncoplastics is technically based on patient decision, but also there are some patients that we need the oncoplastic or the plastic part to be able to preserve the shape of the breast after taking a larger area of cancer. So if a patient has really large breasts and they have a larger cancer, we are able to still do breast conservation while giving them a lift and a reduction. And this is very exciting. Most people, and when I started doing surgery and when I was a medical student, most patients who had a tumor larger than 4 centimeters were recommended a mastectomy. Thankfully, due to oncoplastic surgery and the creation of this idea in our breast surgery world, we're now able to do breast conservation in patients who otherwise would have been recommended a mastectomy. Here at MedStar Georgetown University Hospital, we offer 3 different types of mastectomies. We offer nipple-sparing mastectomy, skin-sparing mastectomy, or modified radical mastectomy. So the difference between them is essentially a nipple-sparing mastectomy is where we remove the breast tissue through an inframammary fold or an incision in the inferior portion of the breast, where we remove 98% of the breast tissue. But we do not touch anything of the skin. We leave everything intact. Not all patients are candidate. There are some patients that unfortunately are unable to have this procedure due to the location of their nipple, if it's too low. Now the skin-sparing mastectomy is the one that is the most common, and those are for patients, any patient can have that, but it's with the removal of the nipple. And there is the modified radical mastectomy, which is for patients who have more locally advanced disease like inflammatory breast cancer, or patients who have lymph nodes that are extremely involved, who require a removal of all the lymph nodes underneath the armpit plus the breast tissue. The patients today that we make the decision for nipple-sparing mastectomy are mostly based on the location of the tumor not being invading the nipple, or of patients not presenting with nipple discharge that is bloody. And the other criteria is if their breasts are too large or their nipple is located below the inferior border of the breast, which is called ptosis. Here at MedStar Georgetown University Hospital, we work very closely with our plastic surgeons to create a personalized treatment plan and surgical plan to be able to provide most of our patients with nipple-sparing mastectomies if it's considered oncologically safe. Reconstruction for breast cancer patients has truly evolved in the last decade or so. When we used to talk about reconstruction, we only thought about patients who had mastectomy. Now when we talk about reconstruction, we also talk about patients who have breast conservation with oncoplastics. So if I was to divide the 2 different patients, the one that has mastectomy with the one who has oncoplastic with breast conservation, the patient who has a mastectomy has several options. They can have something called a DEEP, which is an autologous, meaning your own tissue from your belly is used for reconstruction. This is done obviously by plastic surgery. I do the cancer procedure and the plastic surgeon comes into the operating room at the same time and does the reconstruction at the same time that we operate on the patient and remove their cancer. Now the autologous or your own tissue reconstruction is very natural feeling. Patients are able to feel like their tissue is their own, they don't have an implant in. And a lot of the times, I tell patients that if they gain weight or they lose weight, it changes with time, the reconstruction. Now, not everybody's a candidate for that, and we do have the option of an implant reconstruction or a tissue expander. The difference between a tissue expander and an implant reconstruction, or direct to implant, which is called, is really based on the plastic surgeon's decision. Or there are some other criteria which is, patient driven, meaning if the patient's having radiation or if the patient had previous radiation, or the decision is sometimes made in the operating room. Now, a tissue expander, it's essentially a bridge after mastectomy to be able to put an implant at a later date. An implant is essentially the same that you would get for breast augmentation, but it's done at the same time of the reconstruction. Now, for oncoplastics, when we talk about reconstruction in the breast conserving world, we talk about oncoplastics, which is usually a reduction and a lift, or meaning closing up the defect that we've created by removing a larger area of the breast. The most common side effect of lumpectomy is usually seroma, which is a fluid collection that happens after surgery. That is obviously reversible and it goes away with time, but it's very often seen after surgery about a week or two. The other side effect that I tell patients all the time is that sometimes we operate on patients who don't have a palpable finding, and I see them in surgery, I see them after surgery in their post-op visit, and they're like, "Doctor, now I have a lump." That is usually scar tissue that forms, and I always tell them that that's something that happens right away after surgery, but it also improves with time. The other complications are bleeding or infection. Thankfully, those complications are actually quite low, and they're less than 3% of patients. There's another thing that we normally talk to patients about. So when we do lumpectomies, we're trying to do something called negative margins, meaning making sure that there are no edges where the cancer is touching. Now, I practice something called cavity shave margins, which has been shown to decrease the rate of positive margins. And that decreases in itself something called re-excision, which is meaning a second surgery to make sure that we go back and clean out the margins. So those are the typical things that we talk to patients about after lumpectomy. One of the most common side effects of mastectomy is chest wall numbness. Now, whether it's partial or complete, it's very hard for us to really determine preoperatively, and it's something that I really talk to patients about. The reason is because when we remove 98% of the breast tissue, we also cut nerves that are close to the skin. So I tell patients that after surgery to not put ice or heating pads because I have seen a lot of patients who don't have feeling and they end up getting burned. And so that's something that we talk to patients about. A lot of them recuperate some of the sensation. They still feel touch, they just don't feel pain, they don't feel hot, and they don't feel cold. Because those nerves are very different, the superficial nerves versus the deep nerves. Other common side effects obviously are the regular complications after surgery, which are bleeding, infection, you're going to have scars, asymmetry. I always tell patients, unfortunately we can't make perfect, but we can make the closest thing to perfect. And also, there is something called post-mastectomy pain syndrome, which is not really the pain that you experience post-operatively. It's almost like a neuropathic pain or a nerve pain that happens usually within 2 years after surgery. It doesn't happen very common, thankfully, but patients who do develop this, benefit from physical therapy. There are studies that show acupuncture is helpful, and there are some medications that are given by our pain specialists that are not narcotics, but they're nerve modulator medication for this type of pain. The type of pain that they experience is not the type of pain that goes away with Tylenol. It's more like a sharp shooting pain or numb or tingling sensation that they feel in their breast. The clinical trials that we do mostly in surgery are truly about de-escalation of surgery. So at the beginning 1970s, we used to aggressively treat breast cancer with surgery. And we've realized that surgery is an important component, but it's not the only thing that is needed for breast cancer treatment, right? So in most patients. And so a lot of our clinical trials have to do with decreasing the amount of surgery, therefore decreasing morbidity for patients without impacting their survival. So a lot of the clinical trials that we do have open have to do with de-escalation of treatment surgically and allowing patients to be able to get other treatment options that are equally successful and not impacting their survival. The role of genetic testing is actually a crucial one that we practice here at MedStar Georgetown University Hospital. All of our patients are recommended genetic testing, and this is based on the American Society of Breast Surgery expanding their criteria from very limited to essentially anyone with a cancer diagnosis should be tested for any mutation, not just BRCA mutation. There are other mutations that are associated with breast cancer and other cancers. So when we talk to patients, I always tell them that this is an important information that they're going to get, and that it's very important for them to know, not only for themselves, but their family members. And also to change their screening approach, not just for breast cancer, but other breast cancers such as melanoma, colon, pancreas. Patients should come to MedStar Georgetown University Hospital for their breast cancer treatment because we are a multidisciplinary center where you will have treatment by all subspecialties, as well as the supporting staff that will guide you through the journey from the beginning till the end.